Welcome to today's FERNE learning session on brain biomarkers and the evaluation of ED patients with mild traumatic brain injury. What is the pathology? What is the clinical benefit of this diagnostic test? And what role does this lab have in 2026? My name is Edward Sloan. I'm Professor Emeritus in the Department of Emergency Medicine, U of I in Chicago. I'm also Medical Director of the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This is the QR code for my information, and I want to thank the people from the Emergencies in Medicine Educational Group who helped provide this original presentation. I have no financial conflicts. I'm FERNE President and Board Chair. You can join us at ferne.org or on social media. And at YouTube, you can join us at FERNE.org, where we have several different playlists, shorts, and longer presentations. This information is available to you using this QR code, and there is extended information including a policy brief, clinical update, and mild traumatic brain injury patient information using this QR code. So what can we conclude and recommend as a result of all of this information? Regarding the clinical indication and utility of brain biomarkers, we conclude that these biomarkers have a primary role and indication as adjunctive tools to what are our current strategies for determining the need for neuroimaging in mild TBI patients with GCS of 13 to 15 within 12 hours of injury. So we recommend that institutions should begin to consider how to use these brain biomarker tests as an adjunct and an addition to the current process of determining the need for neuroimaging in mTBI patients within 12 hours, especially in adult patients. What do we conclude regarding clinical performance of these brain biomarkers? We know the performance profile suggests that these lab tests are extremely sensitive, sensitivities up to 98%, with negative predictive values up to 100%, such that in low-risk mTBI patients, neuroimaging can be deferred when these lab tests are negative. But we also recommend that when these tests are positive, it still is an indication for neuroimaging because the patient then no longer is a low-risk patient. What do we conclude regarding the clinical confounders when using these lab brain biomarkers? We know there has to be caution in specific populations, especially those with advanced age and impaired renal function. We recommend that there be heightened clinical caution. We know that you need to double the cutoff so that there are not so many false positives that the test has no value. And we know that there has to be a similar consideration in those patients with acute alcohol intoxication. What do we know about injury and testing time issues? We conclude that the 12-hour window is the peak window and acceptable, approved window for ruling out the need for neuroimaging in mTBI patients. And we know this window, again, is recommended to be 12 hours or less following the time of injury. What do we know about the prognostic value and what can we conclude? The currently approved FDA-cleared blood brain biomarker tests are not approved to detect the presence of concussion, to predict the speed of concussion recovery, long-term neuropsychological outcomes, or the necessity for neurosurgical intervention. So we recommend that we limit any prognostication using these lab tests only to the need for non-contrast CT neuroimaging in low-risk mild traumatic brain injury patients. What do we conclude about the use of these brain biomarkers in polytrauma patients? We conclude that GFAP demonstrates superior diagnostically as compared to S100B, and we recommend that when there are concurrent injuries or multi-system trauma, GFAP-based panels be used and not S100-based panels due to the improved performance of GFAP in this setting. What do we conclude about the clinical and economic impact of these tests? The point-of-care testing may allow up to 20% of CT scans to be avoided in low-risk mild TBI patients, and we know this may also improve and shorten the ED length of stay. What do we therefore recommend regarding the use of these lab tests? As able, institutions should implement point-of-care testing in order to leverage rapid turnaround times of less than 20 minutes for this lab test. This will allow triage to be sped up. It will allow ED throughput to be increased and ED length of stay to be reduced. What do we conclude regarding maximizing the clinical adoption of this useful lab test? We acknowledge and conclude that there are logistical and economic barriers that may make broad adoption of this lab test platform to be utilized. We therefore recommend that institutions develop multidisciplinary task forces that can understand how protocols can be standardized in their institution for the management of patients with mild traumatic brain injury, including test ordering that includes lab biomarkers and non-contrast CT. What do we conclude regarding general neuroimaging indications in patients with mild traumatic brain injury? Because head CT neuroimaging is clinically useful and well understood, and because it is cost-effective, liberal use of non-contrast CT is still justified regardless of the presence of lab brain biomarkers. We expect, therefore, that the initial reduction in the use of head neuroimaging in this setting will be modest. We recommend that test optimization be studied in individual institutions over time, examining clinical use by clinicians, patient outcomes, and what are overall healthcare costs, including reimbursement. What do we conclude, therefore, regarding neuroimaging in anticoagulated patients? In general, we conclude that anticoagulant use most often causes risk to exceed minimal risk. Therefore, most patients will not be classified as being low risk. Therefore, it makes sense to examine the dual testing of brain biomarkers and neuroimaging with non-contrast CT in a series of patients who are anticoagulated to determine whether or not this lab test assay provides value in patients who are anticoagulated and who are defined as being not low risk simply because of their anticoagulation use. It may be demonstrated that because so many patients have a positive CT finding on initial neuroimaging, that the lab assay will not provide much value in this subset of patients. Alternatively, however, if it can be demonstrated that in these patients, the number or percentage of patients who have an intracranial lesion is so low that these patients can still be defined as being low risk if their lab testing is negative. So this is an important area for research, especially in those institutions that see a large number of older patients who are anticoagulated. What do we conclude regarding alcohol use and acute intoxication in trauma patients? We conclude that alcohol use confounds biomarker use, and when patients are clinically intoxicated with an elevated alcohol level, the test will be less specific. We know, however, that there will not or should not be a greater number of false negative biomarker tests, which is the current concern of the clinician when attempting to optimize the outcome of trauma patients. So what do we recommend? As was the case in patients with anticoagulation, a series of trauma patients in whom intoxication is present, there should be dual testing, both biomarker lab testing and CT neuroimaging, in order to determine whether or not the presence of intoxication is causing problems to occur, especially the presence of more false negative lab tests. It may be seen that despite the fact that there is acute intoxication, these lab biomarkers still may provide value in attempting to reduce the need for neuroimaging in mild traumatic brain injury patients with GCS scores of 13 to 15. What do we conclude when we consider guidelines and decision rules? We conclude that the modified Canadian head CT rule for minor head injury clearly identifies a mTBI patient population for whom neuroimaging is indicated. However, we recommend that in addition to the use of guidelines such as this Canadian head CT rule, that the use of lab brain biomarker tests begin to be initiated in institutions throughout the country and the world in order to determine how lab testing using brain biomarker assays can modify and enhance overall guideline use and improve the outcomes of patients through the reduction of neuroimaging in mild traumatic brain injury patients. So what do we conclude regarding how we can enhance patient care? In order for clinicians to learn how to improve the care in the acute setting of patients with mild traumatic brain injury, that the use of organized conferences, remote learning, internet content, social media, and AI be utilized in order to allow for the greater adoption of optimal testing strategies, including the use of brain biomarker lab tests. We therefore recommend that when optimal mild TBI patient testing strategies are learned as more institutions institute protocols, that these optimal strategies for testing, both lab testing and neuroimaging, be provided to clinicians by teaching in these multiple modalities, both live and remote. So what do we conclude when taking a clinician's perspective? The goal of performing tests is to achieve optimal patient outcomes using tests that are clinically efficacious and cost-effective. Therefore, we recommend that clinicians continue to liberally use head neuroimaging when clinical gestalt suggests a greater than minimal patient risk. However, we also recommend that we learn more about the success of biomarker test use in improving patient outcomes by monitoring patient outcomes, decreases in head non-CT use, ED throughput, and the cost of care. What do we conclude regarding the use of protocols and the electronic medical record for patient benefit? We know that optimal mTBI patient diagnostic protocols are constantly being developed, and we know that there are several clinical factors that will optimize the use of tests such as lab brain biomarker tests. We therefore recommend that institutions have their own local protocol developed within their hospital or their hospital system, and that these protocols be integrated into the EMR for automated data collection, facilitated decision-making by the clinician, and easy ongoing CQI activities. So what is the clinical takeaway from all the information we've learned during this FERNE session regarding the use of lab brain biomarker tests in the optimal management of patients with mild traumatic brain injury? So regarding brain biomarker lab testing in mild TBI patients, there are several clinical use considerations. When the clinical suspicion for injury is not low in mTBI patients, non-contrast CT neuroimaging should liberally be used without biomarker use. This is still the standard of care, providing non-contrast CT when risk of injury is considered to be not low, that is, moderate or high risk. However, when clinical suspicion is low, liberal brain biomarker lab testing is a good idea. Why is that? Well, brain biomarker lab testing helps the clinician by providing a concrete data point that confirms the suspicion that this patient is at low risk. Also, this type of data point will allow the clinician to assure the patient that their risk is low and that neuroimaging is not necessarily indicated at the present time. We also identify that point-of-care brain biomarker lab testing may be optimal by providing point-of-care testing in the acute setting. This allows results to come back quickly. It allows the patient to be seen quickly if they still happen to be waiting for an ED bed. It allows throughput to be enhanced. It allows the number of CTs to be reduced, and it allows the patient to be dispositioned more rapidly than if the test is not done as a point-of-care test in the emergency setting. Lastly, it is worthwhile for institutions to develop a protocol using both non-contrast CT and biomarker lab use. In patients in whom the question of the utility of the test remains, such as those who are older, those who have renal failure, those who are acutely intoxicated, those with multiple trauma, those who are anticoagulated, all of these patients would benefit from a protocol that utilizes both non-contrast CT and biomarker use. If it's possible then for institutions to develop protocols that address these specific patients with more specificity and in greater detail, these protocols can be shared so that more institutions can optimally care for the patients who have these specific confounding variables that may influence the utility of brain biomarker lab testing in mild TBI patients. So let's wrap up. What is the better future that we see in patients with mild traumatic brain injury in whom non-contrast CT neuroimaging might be deferred and in whom lab brain biomarker tests may provide value in reducing the number of neuroimages required? So when considering mild TBI patient care, let's look to the future. If you look at the right on this screen, this is the James Webb Telescope that is looking back 13 billion years in time and seeing these galaxies as they begin to form. But let's look to the future. What can we see? I believe there will be greater scientific advancements, especially the use of protocols that test both with brain biomarker labs and non-contrast CT neuroimaging in mild TBI patients, both those who are adults and in pediatric patients. Technologies such as BrainScope that looks at real-time concussion evaluation may improve our use both of these two tests and that test. The more we learn about NFL and tau proteins and other measures of injury and inflammation, we will learn more about how to optimize mTBI patient care. I think with expanded education and clinical adoption, these tests will improve patient outcomes and reduce healthcare costs. I think continuous quality improvement activities at all institutions will enhance the utility of these tests. Integration into the EMR and the use of AI will support our improvements in test utilization. And I think all of these will lead to improved patient care and optimal resource use. And ultimately will allow for more consistent and appropriate reimbursement for the care we provide for our patients with mild traumatic brain injury. For more information, go to FERNE.org, where you can find content relevant to your clinical practice. We're also available on social media and on YouTube at FERNE.org. You can find playlists and video content that will improve your patient care, patient outcomes, and your clinical practice. So with that, I'd like to thank you. And if you have any questions, you can email me at my email below. And always go to FERNE.org for finding more information regarding how these tests and other strategies for providing optimal patient care will improve patient outcomes and allow for us to optimally utilize our limited healthcare resources. Thank you again for participating in this educational program.